Today I wanted to go over relaying unexpected findings, in particular, what are unexpected findings? And there are a list of different pathologies that various organizations have produced to indicate what they would deem a, a finding that, as radiographers, if we see them, we really should notify a radiologist or a doctor of their presence, because remember, you guys are the first people that see these images. So it's very important that if you do see something of these natures, that you notify someone, because we don't want to leave something urgent, because it could end up being quite a while before they're seen. So, as part of the MRPBA professional capabilities, which is what governs your registration as a radiographer, you need to evaluate medical images and identify any urgent and or unexpected findings. That's domain 1, capability number 7. So this is actually written as part of your registration, and as part of your continual professional development. It is our responsibility as a profession to make sure that we don't fall back in our ways, that we continually learn what these urgent findings are, and for us to always remember that there is a patient at the end of that. So if we can expedite their care, it's always in their best interest, but also in our professional registration standards as well. So what do? We need to take appropriate and timely action to ensure that this patient gets management. And so if you see something, you need to make sure you voice it, whether it be to a qualified radiographer, or whether it be to your tutor, someone that you know is going to expedite something. Or if you're unsure, just speak up. I would always much encourage you to say something, and it be completely normal, then not say something, and we send someone home with something that we probably should have actioned right then and there. So I really encourage you to please try and remember to look at your pictures before the patient goes off, to make sure that you don't send the patient home with anything unnecessarily. So the first pathologies, or set of pathologies, would have to be intracranial hemorrhages. By far the most common cause of hemorrhages in the brain would have to be a fall. In terms of imaging, CT is often the most useful in the acute setting, and usually for post-trauma. MRI is often very good if you're looking for an underlying brain abnormality. So if it's not for a post-fall, but you're looking for a reason for a hemorrhage, MRI might be a very good tool to use, because MRI's density and contrast sensitivity is much greater in brain imaging than it is in CT imaging. So MRI can be employed in those circumstances. So in terms of CT, we have to be mindful that, unfortunately, due to the mechanism of the blood congealing, we may not see a bleed in the initial stage, because when blood first pools, it may have the same Hounsfield unit, or it probably will, have the same Hounsfield unit as the normal blood which it has come from, because pooling blood, or blood that's leaked out of the vessels, will look the same as normal blood until it has had time to form a blood clot. So they usually say within the first hour or two you may not see any changes, but in the acute setting, so usually 2 to 3 hours afterwards, you should be able to see an increase in density within the brain to be able to see if there is a bleed. And that's what we look for in a non-contrast CT brain study, if there's an increase in density somewhere. There are some classic spaces that blood might pool, and they're listed there. And these hemorrhages often occur because of trauma, so extradural, subdural, and subarachnoid hemorrhages. I won't mention contusion today because for time limit, but also they're quite difficult to identify by themselves. in the sense that you can't differentiate them sometimes from the other three. So I would just encourage you to know that the top three there, extradural, sometimes called epidural hemorrhages, subdural, and then a subarachnoid as well. So moving on to the next slide, this is the classic appearance of a epidural or extradural hemorrhage. Extradural hemorrhages form from a bleed that has leaked into the skull cavity, which blood has pooled between the skull bone and the upper layer of your dura mater. And because the dura mater is attached to the skull at the suture lines, you often have these classic bulging appearances these hemorrhages can be quite a bit of a problem, because even on this diagram, can you imagine the amount of pressure that the brain is currently on? The other problem that we have with the brain, and this is a very unique situation, is that the brain is a very solid structure. The actual bone itself is very solid. It's not going to move. So any increases in density, whether it be from a lesion, whether it be from vasculature increase, hypertension, those kind of things, it's going to cause the brain to swell or cause the brain to shrink. And so the skull vault isn't going to move. This particular hemorrhage has caused this space to enlarge, and because this space has enlarged, the brain has to give at some point, and so these hemorrhages can often cause herniation, midline shifts, and various other things. The next thing is some examples. So, can you appreciate that this patient hasn't been given any contrast? If we gave the patient contrast, your sinuses would be full of bright white stuff. So your sagittal sinuses are not filled with any contrast. And can you appreciate this big, massive white bulge here? That is an extradural hemorrhage. It's a classic sign. There's midline shift and there's effacement of your ventricles. So your ventricles are no longer visible, but you know they're there. They're just not visible due to how much pressure this extradural hemorrhage is causing. I think there's another example on another compartment, but you can see here that this must be the frontal suture, this must be the squamosal suture, and because of that, this hemorrhage is contained within this space, causing a midline shift towards the patient's right-hand side there. And on the bone window, you can see the small fracture there that's caused it. So this most likely is a head strike. They've probably knocked one of their small vessels, and those small vessels has now perforated and caused this extradural hemorrhage. Interestingly enough, this is a very common space to have a bleed because this is the weakest part of the bone. The pterion is the amalgamation of all the bone plates into a very small spot. It's a very weak spot, and head strike often causes a fracture through there. So unfortunately, at the same time, the weakest spot has a very large blood supply. So this is very common for a lot of rugby players and a lot of head-on tackle sports. So the next type of bleed that I would like you to know is a subdural hemorrhage. So subdural hemorrhage is another type of brain hemorrhage, and it's all to do with the layers of the brain. So this is actually a bleed into the space below the dura mater. So directly below the dura mater, but in front of the arachnoid space. So because the dura mater and the arachnoid space isn't really connected, these bleeds often move around the brain until they reach another suture line. They also form this crescent shape because they don't exert as much pressure often because there's more space, there's more room for the blood to move around. So it has this classic, as the textbooks would describe it, a crescent moon shape. And I'm not sure if you can see here, but normally the reason for these bleeds is a small vessel within the arachnoid space has perforated. So the next slide is some examples. So you can see here this classic crescent moon shape. It normally goes from front to back, and it normally is quite peripheral as well. In this particular instance, is causing a herniation here. So this is your the area where your lateral ventricles would normally sit. Your lateral ventricle is now over here, and it's a herniation because you can see your actual lateral ventricle, as opposed to the previous picture where it was effacement, where the lateral ventricle has been compressed completely. This particular structure has exerted a bit of force onto the brain and caused this side of the brain to actually herniate across your falx cerebrali there. So onto the next picture. This is the other type of bleed, is a subarachnoid hemorrhage. These will be the bleeds that bleed directly underneath the subarachnoid but between the pia mater. And because of how the brain works, they often move around the brain gyrus and sulci and to kind of fill the void. So the classic spaces that you would see them is where the circle of Willis is down here, classic kind of like spidery appearance. That's very common, and that's the space that a lot of radiologists would often look at to see if there's a subarachnoid bleed. Unfortunately, because of how much space the blood has to move around, being able to see a subarachnoid bleed can be very dependent on the amount of blood that has pooled, because CT needs a bit of blood to be able to differentiate the two densities. MRI, because it's independent of subject density, it works on the tissue signals. Subarachnoid bleeds are often much better appreciated on MRI. Okay, so I wanted to summarize the brain intracranial hemorrhages with this statement, is that if you ever see any pathology that causes any midline shift, that is warrant for an escalation to a radiologist or any doctor. Any midline shift is not a good shift, and we must make sure that someone knows about it. This is not a traumatic bleed, but it is a metastasis that has caused a bleed, and that has caused a slight midline shift there from the patient's left to right, as you can see. All right, moving from the brain, we move into the abdomen. Another pathology that I think is really interesting is called a closed loop obstruction. A closed loop is when a loop of bowel becomes obstructed at a single location. So you can see here that there is a single loop of bowel here, and for whatever reason, it's become stuck at this point here. So the most common reasons would be adhesions, a post-surgery shock to the bowel, or various different mechanisms where this part sticks together and eventually it becomes very difficult for things to move through. Volvulus or volvuli, again, very similar to this example, except there is a twisting. So there's a double whammy here where the bowel sticks to itself and then twists on the same spot due to movement inside the bowel, and that is bad. So there's a couple of x-rays that I'll show you in a second which give it a very classic appearance. And of the closed loop obstructions, all I would like you to notice is volvulus, because that's very important. It's very easy to identify, but also very easy to notify someone of as well. So as I mentioned, I would like you to have an idea of what a volvulus is. There are two general types of volvuli. That is a sigmoid volvulus and a cecal volvulus. The most common by far is a sigmoid volvulus because the actual sigmoid bowel itself moves a bit, and because of that ability to move a bit, it has the ability to twist on itself unnecessarily. So because of the twisting and because of the location of the sigmoid volvulus, the bowels often move in the direction the arrow has said. So you have this classic appearance. It's called a coffee bean appearance here. And then the area of twist for a cecal volvulus is over here, because that's where the cecum is. And it normally goes in this direction. So some pictures of what volvulus looks like. So this is a classic appearance of a sigmoid volvulus. The twisting itself would be somewhere down here, and this is one single loop of bowel that has twisted on itself. And why is the bowel so large? Because the bowel is a living part of the body, and so it produces gases, it produces various different means of excretion, especially the large bowel. That's how we have funny little noises sometimes when we sit down. And all of these gases are just building up inside your large bowel. And so, what does the large bowel do? Well, it can't get rid of it because it's obstructed, so it just gets larger and larger. And at some point, this bowel may perforate, and that's what we don't want. So, if you see something like this, please make sure you notify one of us or notify a doctor when you're qualified. All right, so I think the next one doesn't really need an introduction. NGTs get misplaced into the wrong body cavities sometimes, and it's no one's fault. It can just happen because it's difficult to place post-surgery, anatomy is different, etc. And for those who don't know, this is what an NGT should look like. It should be placed into the throat, travel down the esophagus and into the gastric space over here. Unfortunately, sometimes the NGT may not be placed inside the throat, inside the esophagus, but may be placed inside the throat, but inside the trachea instead. So it may deviate down the left or right main bronchus. So what we'll do is we'll have a look at some examples of misplaced NGs and see. So you can clearly see here that this NGT is clearly down the wrong spot. It's kind of had the right trajectory. It's heading in the right side because, the stomach is on the patient's left-hand side, but clearly the NG is not midline and not below the diaphragm. So this is what they normally describe it as. The NGT should be traveling straight down the center, should be midline, should go underneath the diaphragm and then sit in the gastric bubble area. But unfortunately for this, it clearly looks like the NG tube has traversed the left main bronchus and then into part of the lung. So that needs to be pulled out relatively quickly. The reason is this now means that this patient has decreased lung function on the left-hand side, and if this NG is really obstructive, it may actually mean this whole section of lung is not being aerated with any air at all. That also means the patient can't expel gases very well, can't expel carbon dioxide very well, leading to other problems as well. So the perfusion and ventilation is not very good at the moment. So I think this is an example of a misplaced central venous catheter. So central venous catheters often are put in during surgery. They're often put in during various different treatment regimes, and they should go from the jugular access point up in the neck here, straight down into the sinoatrial junction, which is over here. So what's happened is the jugular vein has done a UE and gone down the brachiocephalic vein. A right-sided central venous catheter, or CVC, is by far the most common. The reason why this is the most common is because the right jugular vein forms a direct connection with the superior vena cava. If you were to insert the same line on the left-hand side, it would actually have to make a sharp right turn from here, sharp right turn, and then traverse down the SVC. So often in theatre, without imaging guidance, they would always elect to do the right-hand side because the right-hand CVC is generally quite a straight course, and it starts from the top and it works its way straight down. So in this case, is this line safe? It is safe. It's not in the wrong spot. It hasn't perforated the lungs. It hasn't, but it's not effective. So if this particular patient needed drugs directly to the central system, well, what's going to happen is the drugs will go up here into the arm, and then it might come back, or it might go up further and then come back. So you do lose the effectivity of this line. If they're drawing blood and they're expecting to draw blood from the heart, it may give a false readings. So in terms of, is it critical? No. But is it notifiable? Probably. We probably should notify the physicians, let them know that their CVC line is heading in the wrong direction. It's not in a critical position, but it's in the wrong position. So with the next slide, one of my favorite things to teach students is looking at pulmonary emboli. So this is a CT of the pulmonary vasculature, and an emboli, as a revision, is essentially a blood clot that has broken away from their sites of origin. Normally, for most emboli, it is a deep vein thrombosis that is broken off, so it's not uncommon for us to do a CTPA and then ultrasound to perform a leg vein thrombosis check. So this is very, very common. You also hear stories of these occurring for people who've had like long haul flights across the continent, and so compression socks and moving toes and feet are always advocated in those scenarios. But for patients at my workplace, a lot of these could be drug related, so various drugs can affect the clotting ability or improve or alter, and so blood clots can be a problem. These patients often will have chest pain, tachycardia, pleuritic chest pain, etc. Pain radiating to the shoulders, etc. So that's also very common as well. Hopefully you've managed to spot the pulmonary emboli here. This is the pulmonary trunk. The pulmonary trunk should be white all the way from the bulb to its bifurcation. So there's this regions of hypodensity here that resemble emboli. Emboli can be small, it can be large, it can be quite inconvenient. I've emphasized here the importance of finding large emboli. Remember that we are radiographers, and we don't diagnose the patients, nor do we have time to sit there and look at all these studies in good scrutiny. But I think as part of our responsibilities, it's important that you notice big pulmonary emboli. So that's why I've only indicated images of emboli within this region, because these are the emboli that could lead to a patient's death if we don't diagnose it, they don't do something about it sooner. So this is an example of a saddle embolus. A saddle embolus is just a fancy name for an emboli that kind of sits over both the left and right pulmonary trunk. Well, I'm not sure if that's common or not. They will need to see someone, and whether they get admitted or whether they get drugs to take it home is up to the clinicians to decide. Okay, so another example of a pulmonary emboli, except this one here, you can see there's almost a complete stoppage of contrast going into the right lung there. So this patient must have decreased lung function. My next slide is another example of a pulmonary emboli. I was really keen for this one. You can see here there's a small emboli here. If you miss this, would this be a huge problem? If this was the only emboli, probably not. But if this was a larger, if this emboli was part of a larger complex that you could clearly see on the trunk, it would be disappointing if we missed it. So I think be observant, especially when the clinical scenario is clearly looking for emboli. If we miss an incidental finding, for example, we're doing something that wasn't related to looking for an emboli and we missed it, it probably wouldn't be a big issue. But then again, we all should be checking our pictures before we send our patients off anyway. So have a good look at the main spaces, the pulmonary trunk, the lungs, the abdomen. A quick 20-second look over will mean a lot, and we potentially could change and alter the patient's treatment course. All right, so the next, I think the last pathology as well is a pneumothorax. These can be spontaneous. That was meant to say traumatic, not traumatic. And they can be iatrogenic. So they can be the result of a medical intervention. They could be the result of us doing something in and around the lung vicinity. So that's the same reason why for the previous CVC slides we did a chest x-ray, because in the CVC example they were putting a central line into the neck and entering the lung. There is a small chance that when they did that they could have punctured the actual vessel wall, pierced through the lung and caused a pneumothorax as well. So that's why we do chest x-rays, not just to make sure that the central line is in the correct space, but also to make sure that we didn't produce a pneumothorax unnecessarily. Hopefully you can notice here that on the patient's right-hand side, there are lung markings all the way to the periphery. You see these speckled appearances all the way to the edge here, but on the left-hand side, you can't see anything at all. So all of this is extrapleural air, so air that's being introduced from the outside into the patient's lung cavity, and this is actually the lung itself. So this is the collapsed lung, just there. So this is a very extensive example of a pneumothorax, and another reason why we always make sure we consent the patient appropriately and tell them that there could be this, because this is most likely a failed attempt at a lung biopsy. Not only have the operators produced a pneumothorax, but they've also introduced what I would say a very extensive amount of subcutaneous emphysema. So all the black things that you see on the topogram chest X-ray and the chest CT scan itself is air inside the subcutaneous space. So what would happen now is, well, the subcutaneous emphysema, they will probably leave for the moment, deal with that separately, but the most critical thing is to return or resolve air function and respiratory function. So they'll put a chest drain in to drain the air. And another thing that might have occurred, actually, now that I think about it, is this could be the result of a failed attempt of a chest drain. There is just such an extensive amount of surgical emphysema that I'm not quite sure whether it's one event or a combination of various events, but chest drain, failed lung biopsy, any of those, or combination of everything. All right, so I did say that this was going to be an interactive